The DELIVER trial. Heart failure with preserved ejection fraction probably represents about half of all of our patients with heart failure and is associated with a substantial morbidity and mortality. There is a paucity of evidence-based therapies in patients with HFpEF. However, the EMPEROR PRESERVE trial demonstrated a reduction in cardiovascular death or heart failure hospitalization with empagliflozin in this population. Uncertainty remains regarding the efficacy in several groups. There's been concern about attenuation of treatment effect in patients with EFs above 60%. There's limited data with those initiated on treatment during or soon after hospitalization, and those with a previously reduced ejection fraction that has improved to greater than 40%. DELIVER was a randomized double-blind placebo-controlled trial testing the hypothesis that dapagliflozin would reduce cardiovascular death or worsening heart failure in patients with heart failure and a mildly reduced or preserved ejection fraction. Patients with an ejection fraction above 40% were randomized to dapagliflozin 10 mg daily versus placebo. Patients had NYHA class 2 to 4 symptoms and an ejection fraction over 40%. Patients who had a prior left ventricular ejection fraction less than 40% were included if EF improved to over 40% at the time of enrollment. Patients had to have evidence of structural heart disease evidenced by LVH or left atrial enlargement and elevated natriuretic peptides. They can be enrolled either as ambulatory patients or during a hospitalization for heart failure. The primary endpoint was time to first composite of cardiovascular death or worsening heart failure. Secondary endpoints included total heart failure events and cardiovascular death and total symptom score. 6,263 patients with HFpEF or HFmEF were randomized. 3,131 patients were assigned to the dapagliflozin arm, and 3,132 patients were assigned to the placebo arm. Patients were followed for a median of 2.3 years. Here are the baseline characteristics. It was well balanced between the treatments. Mean age was 71 to 72 years, but 44% were women and 45% had diabetes. Baseline ejection fraction was around 54%, with 70% of patients having had an EF less than 60%. 18% of the patients had a prior ejection fraction less than 40%. About 40% of the patients had AFib, and about 3/4 of the patients were NYHA class 2. The NT-proBNP levels were shown here in patients with atrial fibrillation and in those without atrial fibrillation. The mean eGFR was 61. When it comes to underlying medications, about 77% of patients were on loop diuretics and over 80% on a beta blocker. About 80% of patients were on a RASI or ARNI therapy. About 40% of patients were on a mineralocorticoid receptor antagonist, which is the highest of heart failure trials in patients with mildly reduced or preserved ejection fraction. In terms of primary results, there were 610 events in the placebo arm, representing 9.6 per 100 patient years. The dapagliflozin group had only 512 events, representing a rate of 7.8 per 100 patient years. This gives a hazard ratio of 0.82, a significant result with a p-value of 0.0008. The number needed to treat was 32. Here you can see the pre-specified result in the subpopulation of patients with an ejection fraction less than 60%. This shows that there is virtually no difference in the ultimate result from these two groups. Looking at the components of the primary endpoint, the majority of benefit seems to come from a worsening heart failure event, which was reduced by 21%. Cardiovascular death was reduced by 12% but was non-significant. Primary endpoints in pre-specified groups. Here you can see there's no heterogeneity based on ranges of the left ventricular ejection fraction. Specifically, there's no evidence of attenuation in the highest ejection fraction group. There was similar benefit for patients enrolled within 30 days or during hospitalization. There was similar benefit in patients with improved ejection fraction compared to consistently greater than 40% ejection fraction. There are numerous other pre-specified subgroups. There were no outliers who did not get benefit, but just to highlight a few, the results were very similar regardless of diabetic status. There was no difference among males or females or based on eGFR above or below 60. In terms of secondary endpoint, the first secondary endpoint was total heart failure events and cardiovascular death. There was a reduction in not just the first hospitalization in cardiovascular death, but also in recurrent events, as you can see on the left, yielding a rate ratio of 0.77 and a p-value of 0.003. The total symptom burden using the KCCQ score showed the total symptom score from baseline to 8 months was statistically better in patients receiving dapagliflozin. For any serious adverse event, any adverse event leading to a treatment discontinuation or treatment disruption, there is numerically fewer patients in the DAPA group than in the placebo group. There were very few numbers of amputations, DKA, or major hypoglycemic events. In summary, DELIVER is the largest and most inclusive trial of patients with heart failure and mildly reduced or preserved ejection fraction. Treatment with dapagliflozin reduced the risk of the primary composite outcome of cardiovascular death or worsening heart failure by 18% with an NNT of 32. Dapagliflozin was as effective in patients with recent hospitalization and in those with prior reduced ejection fraction that improved to over 40%. These findings were consistent across pre-specified groups, including those defined according to left ventricular ejection fraction with no attenuation in the highest ejection fraction group.